There you go. I'm going to change my corporate branding as well. I'm taking it off for something else. This is Tony from the LMC. Hi, Tony. You okay?
Yes, thank you. You?
Very well indeed. We're just about to start, so I think I'll. If you could just ask for the recording started. Thanks very much, Lynn. So welcome everybody. This is the governing body, the public part of the governing body for the CCG. And just in terms of apologies, I have a few apologies. I've got Helen Horton, I've got Louise, but Nikki's standing in for Louise, and we've got Ed Tallis as well. So they're the three that I've got. Brenda, you've got any more other than that? I think that's it, is it? I can't see anybody else missing. I see Charles is here and Peter's here, yeah.
I can't see Colin on the call.
Oh, no, yes, that's correct. Yeah, so we'll put down Colin at the moment then. Oh, here he is, right on cue, Colin pops up. So welcome, Colin. Okay, so just in terms of then of items on the agenda, declarations of interest wise, I don't think there's anything unless anybody's got anything they particularly want to shout up. I've got to look through. I'm obviously particularly looking at GP colleagues in that regard, but I don't think there is anything at all. Okay, I don't seem to see, do we have any members of the public joined us at all? Oh, is David? Just let me in. Hello, David.
Hello there, sorry to be a little bit late.
But just so you know, David, I was just going through the welcome apologies and everything like that. So I was just going to say there's Peter Scott within that as well. I would imagine Brenda from the Trust, because obviously he's one of the members of the, as an observer. We've just done declarations of interest, David. I don't think there's anything from your perspective wise, declaration wise within that. And I was just going to move on to the minutes of the governing body meeting held on the 20th of January, just to make sure that there's nothing in there in terms of accuracy. So just wanted to, anybody shout up if they've got anything. I'll go through the pages, page 1, 2, 3, 4, 5, 6, 7, and 8. Everybody okay with that? Yeah. Okay. Has anybody? There's no actions arising from that directly on the action log, but is there anything matters arising wise that people want to pick up that is not going to be covered on the agenda? Okay, that's fine. I'll take that as a that we're happy to move on. So I'm going to then move on. I just want to know how you're going to do this, Peter, because I'm aware that Ed's not here in terms of anything to do with vaccination, and I don't know if he's put anything in place regards you picking it up or not, Peter, but are you able to pick that up? If not, anybody else might be able to pick it up very briefly.
No, that's fine. Good afternoon. Thank you, Chair. Just a few quick things around COVID, including the vaccination issue you just mentioned and the urgent care pressures. So in summary, Chair, nothing major to really update on in terms of a major change. There's still very high levels of pressure across all health and care services. Partly still an impact from COVID. There are still very high community transmission rates, though. In the coming weeks, it will be less easy to understand the exact numbers, etc., locally, as the national testing arrangements change and largely wind down. So, just for clarity, for everyone's benefit, the community testing resources put in place through the United Kingdom Health Security Agency and others are all ending here in Cumbria and elsewhere across country by the end of March. So that will really reduce the amount of data we have around local epidemiology, etc. But we still do have very high case rates, particularly amongst the younger populations, though not exclusively. And still big pressure in the NHS, most easily seen really through the pressure in the urgent care system for the hospital provision particularly, including that there are still high numbers of service users who are what will be termed medically optimised or do not meet the criteria to reside. So they should be receiving care in a different setting, but are still in hospital because that care is not always available in a timely way. That's partly a function of the pressure in adult social care, both the residential and domiciliary sector. And in terms of the residential sector, still very high numbers of outbreaks, so homes with 2 or more residents or members of staff with a positive test. Nikki may want to say more about that. So overall, still very significant pressure, still high COVID rates. Thankfully, as we've discussed previously, the last wave of COVID has not had the same level of impact in terms of severe disease, hospitalisation, and sadly people losing their lives, mostly because of the benefit of the vaccine programme and high levels of natural immunity, because so many of us have had this virus now. In terms of the vaccine programme, just to re-emphasise, all the vaccine delivery routes, so through general practice and community pharmacy, still operating an evergreen system. So for people who haven't come forward previously for first, second, or where applicable, third vaccine, people can still do that. Lots of encouragement for people to come forward, and still some longer term national discussions about the future of the programme in terms of subsequent top-up vaccine delivery, but nothing materially different to what we've described at previous governing body meetings, Chair.
Okay, thank you, Peter. Are there any particular questions on that you want to pick up? Nikki, anything you wanted to mention, bringing about care homes before then? Yep.
I was only just going to add that in terms of numbers, we did see a little bit of a decrease earlier on, but that has now risen again with the increase in community transmission, and we're at 28 across our North Cumbria patch that are in active outbreak.
Okay, thank you. David?
Thank you, Chair. Just wondered, Peter, whether or not there's any changes planned to the kind of procedures that staff needing to follow in terms of mask wearing and testing and so on. I know the report says that there's face covering still to be worn in health and care settings, but do we know for how long and what that's likely to look like moving forward?
In short, no. So you may well expect over time, David, that some of the infection prevention control measures that are in place may begin to be reduced, but they are still active now. And there is a little bit of a dissonance, I think, particularly for members of the public who are now, freely able to go about their lives without those kinds of restrictions, but they do still apply in healthcare settings, and that can be a bit jarring for people. The really simple explanation of that is within healthcare settings, there are, by definition, a lot higher percentage of people there who are more at risk of a bad outcome, hence those protections being in place. And sadly, we still do have levels of outbreaks within hospitals and nosocomial transmission that still needs to be managed. But the longer term approach to changes around that are still under national and local consideration.
Thanks, Peter. Okay with that, David? Yep. Any
Yes,
other questions? Yeah, thanks, David. Any other questions or comments, John?
It's just a question for Peter about the next round of the fourth booster or the fourth vaccination for over 75s. When does that start, Peter?
Yeah, so the confirmation is for the over 75 population, but also the over 12 population who are immunosuppressed and more at risk. So those vaccines will begin to be offered relatively shortly. I don't know if either Mandy or Colin might have a precise detail on that, but I certainly haven't seen a confirmation as to the exact rollout date, but the expectation is that there will be a routine, regular top-up vaccine offered to that population, and then there's ongoing consideration nationally about whether the other JCVI cohorts may be offered something like an annual vaccine delivery in the same way that people are for seasonal flu. But those things are, to my best knowledge, I've been away for a few days, but to my best knowledge, they're not confirmed in terms of dates.
Thanks, Peter. Nikki, anything you wanted to add to that?
Just in terms of going back to David's original question, the national team are expected to publish an IPC manual for England to actually sort of look at some common principles and try and get a pathway back to normal. So we're waiting for that to be produced in terms of more guidance.
Okay, Mandy?
Yeah, and I haven't seen a specific date, Peter, like yourself. I think all we've seen so far in the literature has been spring.
Okay.
For the booster dose for the over 75s.
Thanks, Mandy. Anything from anybody else before we move on? Okay, thanks for that, Peter, and nice to see you back as well. I know you've not been so well, but really appreciate that. Okay, going to go on to item 5, which is decisions taken under emergency rules for ratification. Charles, I don't think this will take too long, will it?
No, but it might take slightly longer than normal. Not that we've had any decisions, so that's the first thing to note. There have not been any. I raise it now. I was otherwise we've done it under matters arising on the minutes. We said in the minutes we put these emergency measures in place until the end of March, and we would look at it again on reflection. Given for the past 2 years we've been reporting this, and there has not been a single decision taken under these emergency measures. And secondly, with the target date for, if you like, shutdown of the CCG and transfer to the ICB being the end of June, and as far as I'm aware, none of the colleagues around the table have given their notice in, so it's not like we're not going to be quorate for that period. And despite what everyone's observing, that COVID is still very much here, it is not having quite the same impact as it did in some of the earlier waves in the last 2 years. We've decided the straightforward thing will just be to revert to our normal rules of delegation for the next 3 months. So sadly, this will be the last time everyone will hear me say that we haven't taken any decisions under these rules that we put in place. So that's it from me.
Okay, so in effect, Charles, it's a proposal to us to do away with the emergency rules for ratification process.
Yeah, well, in effect, it's a sort of negative proposal, because the emergency rules slip away by default, and we just revert back to our normal ones.
All right, Charles. Brenda, you have something?
Yeah, sorry, Charles. I've just sent you a very quick email. While I've been dealing with the auditors, one of the things that they've been asking for is year-end processes like review of terms of reference, and also GPs completing declarations of interest forms. So I'd just like to ask the governing body to consider keeping those 2 elements of those proposals in place, i.e. we're not going to review all the committee terms of reference as we move towards the ICS for the next 3 months. And also, again, letting GPs get on with their work rather than filling in declaration of interest forms when we're not going to ask them to take decisions.
Okay, so there's 3 things there that we've said: the conflicts of interest for GPs, the doing away with the emergency, and the other. Just remind me of the other one again, then, Brenda. The terms of reference for the
reviewing all the committee's terms of reference, John.
So I suppose what I'm trying to say then is everybody comfortable with that for those reasons? Terms of reference seems pointless for potentially 3 months. Same for conflicts of interest for GPs in terms of what they've got, and the emergencies. We've never had any to do in the time we've had it anyway. So I just club them all together. And is there just a proposer and a seconder, and we can just move on? Proposed by Charles, seconded by Deb. And anybody in disagreement? No. Okay, let's shift on. Thanks for that, for both of you, actually. We're going to move on then to item 6, which is the Chair and Accountable Officer report, and Mark's going to take us through that, and then obviously any questions from anybody afterwards.
Thanks, John. So just a couple of things. Hopefully you've all had a chance to have a look at the report. A couple of things I just want to stress if I can. Clearly, I think everybody knows that Sam Allen has now started in her post as Chief Executive Designate, and we're delighted to have been able to welcome her to the ICB. Sam's putting an awful lot of time into trying to meet as many people as possible, and also to start getting around the patch, because of course it is big. And Sam was in North Cumbria just a week last Friday at the Health and Wellbeing Board, did a presentation and met a lot of people there, and I think that's all very positive. It is the case that work is going on in terms of development and engagement and involvement strategy, also work in terms of the development of the operating model. But in general terms, there is continues to be, in a very positive way, a great emphasis on all of the work that is happening at place and will continue to happen at place as well. So I think that's that is all the direction of travel that we had hoped and would expect. There is something in the report about lifting of COVID restrictions, and we've just had that discussion, and also about vaccinations. So I'm not intending to say anything further about that, but obviously happy for questions, etc. I think it's worth noting that we've had a visit by the Prime Minister, Boris Johnson, to the Northern Centre for Cancer Care, and that's happened in February. I think that was really welcome, and since its opening, I think over 1,000 patients now have received their chemotherapy treatment there. Really positive, but I think it's also worth saying that the centre is run by Newcastle Hospitals, and it just emphasises the very close collaborative links between the North and North Cumbria, and we're expecting those collaborative links to continue on as we go into the new ICB as well. Pardon me. There was a Health Equity Commission summit that's going to be held on the 21st of April, and we've been working with our partners across the ICSs, i.e. into Lancashire and South Cumbria, on that to identify challenges. So we're looking forward to that. Particularly welcome that session is going to be chaired by Sir Michael Marmot. So really important session, and I think everybody is looking forward to being able to hear what Sir Michael says there as well. Just another plug for the Lock in the Lakes conference. I know, speaking to Suzanne, if it hasn't already sold out, it was selling out really quickly. And again, key speakers will include Sir Michael, Colin, and Sam as well. So that would be a really good start to that session for Lock in the Lakes. Just coming back to our operating position, challenges in NCIC, discharges, medically optimised patients continues to be a big issue in North Cumbria. We're not isolated in that. There are other areas of the ICB where it's also an issue as well, for instance, in Gateshead. It is, though, something that is continuing to define our work at the moment. I think the position that we've got to is a lot of the things that we put in place during the highest levels of COVID pressure, those have become business as usual for us now, and yet we still have many patients in the hospital who are waiting to come out, either back to a residential care home or some other care place, and it's still proving very difficult to do that. There has been a chief executives meeting about that, and we are in the process of putting in place a strategic summit across the whole of North Cumbria, which will look at where we go from now. I think we are all of the opinion that continuing to develop the kind of models that we've got now are not necessarily going to get us to the place that we need to be, and we need to think of other things, maybe more strategic things, to get us to a place. So we're in the midst of planning that now. final bit is in terms of primary care filming. So work started on a series of short films about primary care in North Cumbria, and I think this is really welcome. And it'll be used in 2 campaigns supporting the patient and community understanding about the developing roles in primary care, but also about supporting recruitment, highlighting the range of opportunities that there are to come and work in North Cumbria. And this relates directly back to the previous item I've just been talking about in terms of how we get patient flow through the system. And a lot of that is related to the people that we have, the workforce that we have, and we need more people to come and pick up jobs in North Cumbria. So really, really positive here. And, you know, not only does it highlight primary care, but also to specifically help in those 2 campaigns. So, John, I'll stop there and very happy to answer questions if people have them.
Yeah, thank you, Mark. Colin, I see you got your hand up. Over to you.
John, I just would like to put a little augmentation into the report on the Northern Cancer Centre, which is the locality cancer group visited and were shown around by the team, and they showed us some statistics and they discussed how the cancer centre worked. And if anybody gets a chance to go on one of these visits, I would very much encourage you to do so. It's really an eye-opener, just to see what's there and how it's worked. But one of the things I want to observe, John, which is, I think, a theme that we should really play out over this transition period, is that Newcastle Cancer Centre, our tertiary centre, had an extraordinary surge of referrals for first appointment 2-week rule, some of which needed assessments, some of which needed scans. And it overcame their capacity to provide in the tertiary centre hub. They wrote to patients saying, well, actually, we could fit you in Carlisle. Are you prepared to travel to Carlisle? Number one, the patients did agree to go to Carlisle, and that surge didn't overwhelm the situation. The point I make, John, here is that this is 2-way traffic. I'd also point out that the managers of the Northern Cancer Centre, which is physically at the Cumberland Infirmary site, when we were there, were very careful to ensure that they were talking about the part they were going to play in West Cumberland Hospital development of the Henderson suite. And this is really important, John, as you well know. One of our concerns about the hub and spoke model is that it still leaves our West Cumbrian patients with some very long journeys to take. And they're very energetic, very innovative in how they're going to work with the Henderson suite in the redevelopment there, John. So even though we have a Northern Cancer Centre, the Cumberland Infirmary site, and even though that's really important, it is a resource for the whole system, and the staff there are working hard to make the Henderson suite even better and to link with the diagnostics that are present in the West Cumberland site. So I think this is a theme, John, that I would very much ask us to echo in all our conversations as we do transition into ICB. Thanks very much.
Very nicely put, Colin, and exactly what we want to achieve for both the wider system and also more locally between West and, say, the Cumberland Infirmary as well. Fantastic. Any other questions or comments on the report? Okay, right. We'll move on. I just wanted to check with you, Brenda. What time was Molly actually coming? Because she's not here. Because I'll do another item. You see, we've got a few minutes if she's going to come at, say, 22.
I did suggest she join 10 minutes before the the agenda item, but
okay.
She may still got.
Let's say crack on then, and just go to the planning update. Charles, going to hand over to you for item number 8, if that's okay.
Thanks, John. Just to let people know, there is a presentation attached, and when we said we were going to do a presentation, that's because we didn't think we'd have it done in time to go out with the papers. But as we were able to complete that, hopefully people have had a look at it, and I'm not proposing to go through the detail of it, because what it just outlines is what we're doing in terms of planning and where we're up to. So a bit of well, the last 2 years have been very unusual because of COVID, and 22-23 the planning approach feels a bit like a hybrid between moving into the new world, reinstating business as usual, and still dealing with the challenges of COVID that we've just been talking about earlier in the meeting. So the plans initially were ought to be put together at an ICS basis rather than by individual CCGs. The change in the target date for establishing ICBs meant that actually, certainly on the finances, we've had to put together and in the process of doing individual CCG plans because the Department of Health has a statutory obligation to issue allocations to CCG, so it's had to do that. But more importantly, until the end of June, it will be CCGs actually continuing to physically pay providers of care, pay the wages of everyone who works for us, etc. So we do need a budget in which to operate. So as we've outlined in the front sheet, it's sort of been done the other way around. In previous years, we would add up all the individual CCGs to get a North East and North Cumbria position. This has sort of started from the other way, that there's a North East and North Cumbria allocation, and it's been retrofitted back to CCGs. So we're working on that in collaboration right across the whole ICB with all the other CCGs, and indeed locally with North Cumbria in terms of the plans. So the first question, which we can come back to at the end, is just an ask: can we delegate approval of the CCG's budget to next month's Finance and Performance Committee, because we don't have a governing body till May, and then we can take it to the governing body in May for ratification, but that just allows us to continue with our business. In terms of development of the wider plan, there was a detailed and comprehensive summary went to the system exec meeting last week, and we shared a copy at the Finance Performance Committee yesterday. There's a lot more work to do, particularly in triangulating across the activity asks to address the challenges of the new year and how that's reflected in the finances. Most notably, there's a thing which started this year called the Elective Recovery Fund, which is all about a very welcome cash injection to enable additional capacity, hopefully to be put in to bring down the waiting times. And for our region, the North East and North Cumbria, that's an extra £126 million. But it's very complicated. I've heard it described umpteen times, as have my colleagues, and everyone has a slightly different interpretation how it works. So there's been a lot of toing and froing, looking at how do the rules apply to this, the difference between what you need to do in monetary terms as opposed to absolute activity. How do things like patient initiated follow-ups and non-face-to-face things, how do that, it's a really complicated thing. So at the moment, we don't think that the work done to date needs further enhancement as terms of the final plan to get all those things together. So that's just that's just an indication of the sort of thing that we're working through. So as across the country, all ICSs are submitting plans into their regional teams, and they're going into the into the national team. So work will continue over the next month to try and bring those up to date, iron out inconsistencies, undertake peer reviews, particularly on the provider side, to see if everyone's working with a similar set of assumptions in interpretation. And indeed, across all the CCGs, there's been a very, in the North East and North Cumbria, we're looking at applying a common approach to setting contract values with NHS providers, which is very open and transparent. The approach has been shared with every provider, which is a new thing, and a whole set of consistent assumptions to do with likely activity growth and prescribing cost growth, all those things. So it's very much work in progress. So the report here is just to assure people that that work is being undertaken. It's not being undertaken in a vacuum. It's very much in the spirit of taking an integrated approach. And what was very welcome for me at the system executive meeting is that it's acknowledged in the way things are carved up, for want of a better term. The integrated care partnership as it is at the moment in North Cumbria just consists of ourselves and North Cumbria Integrated Care Trust from a financial perspective. But at the next meeting, colleagues from CNTW, colleagues from the County Council, and indeed some primary care network colleagues are going to come and present some information about the situation they find themselves in. So we are trying to work in a very integrated way, and I think that's a real step forward. So the first part of the report was to tell you all about that, and then the second one was just to ask for approval that we take those very pragmatic and practical steps so we can make payments in April. And just to assure everyone, we've applied very similar principles in the current financial year, both at the beginning of the year and then when we had to do the sort of, it was called the H2 budget, because we only got funding in 6 month segments.
Okay, Charles, thank you so much. Any questions or comments from anybody? Obviously, there's more detail in the presentation than Charles has outlined. We all okay? And I know we had a good opportunity yesterday, Charles, from the Finance and Performance Committee to go through it in a bit more detail. So, okay, if there's nothing, first of all, we'll ask the note, which I think, oh, sorry, go on, Colin.
Charles, I don't know, you made a presentation at PRG, and you may remember we had a few clarification questions. And I suppose the issue that most interested me was at the PRG, you were saying the bits of the budget that are growing are primary care and mental health. You may remember this conversation that you and I had, and the idea that we may have to do some work about making that synergistic. In other words, that the rules that come into primary care enable us to develop the mental health offering. I do think it's worthwhile noting here, John, for the governing body, even in highly constrained budgets, there's always areas that we can, if we put some effort into them, get more bang for our buck. Thanks very much.
Okay, thanks for that, Colin.
Yeah,
just
to add that. So again, that's very helpful reminder within the parameters we're working with. It's just to remind everyone the mental health investment standard still applies, which is a key priority. There's some national system development funding to continue and to enhance community-based mental health, and there is also a significant uplift on the primary care budget. We also perhaps expect that, as usually happens, might be matched with significant pre-commitments, but we need to work through that. But Colin's 100% right that whatever we do, there are always bits where even if we don't get more cash, we can strive to get better value from the cash we're doing, both in terms of the synergy that Colin's mentioned, or it might be things like the prescribing budget, where we can offset the cost of growth in new drugs that are very welcome by reviewing how we prescribe. And you know, the adage from all my prescribing colleagues over the years is that if you take quality into account and patient benefits, that also tends to save money, which can be offset against growth. So that's a very well made point.
Thanks, Charles. Any other comments? Okay, we're asked to note it, which we will. But in terms of the approval, it's for a delegated responsibility to finance and performance for the April meeting, in terms of agreeing that operating budget, and obviously then bring it back to ratification in governing body in May, our next formal meeting. Just if people are happy with that, I was just going to ask for a proposer, seconder. Proposer from John. Thank you. Seconder from someone. Yourself, Carol, got that. Any objections to that from anybody? No. Okay. Thanks very much for that, Charles. Appreciate it. So we're going to move backwards. So hello, Molly. How are you? Are you there?
All good from Teesside.
All right. Nice to see you. Literally. There you go. So you're just going to give us an overview on the modern slavery and human trafficking statement. And then we've got an approval to make on that. But I'm going to hand over to yourself, Molly, just for a short introduction around the paper.
Thanks, John. So I'm here because Louise is on annual leave, otherwise she would have been presenting this paper. It is an annual responsibility on the CCG to publish a statement in respect of modern slavery. So I'm imagining people are familiar with this. I've asked Brenda with the minutes from this meeting just to circulate an update in terms of a briefing of modern slavery that's come out from NHS England. It may cover off any questions people have in terms of the subject matter. So within this paper, the CCG have got to produce a statement and publish it. This committee were asking to ratify this statement. It doesn't look unfamiliar from the previous year. The Modern Slavery Act in 2015 and annually has required us to look at this. So the key challenge for the CCG is to ensure that all of our supply chains are free from all aspects of modern slavery. In terms of managing that process and in terms of general awareness, we publish this on our website. The greatest challenge for us is to report progress up to the governing body and the senior execs, to raise awareness and also to ensure that any signs of modern slavery, we act quickly, and any changes in legislation, we adapt our policy and come back to the governing body for that. The greatest risk in terms of modern slavery in our supply chains obviously are our NHS partners. So all the due process has been undertaken, and it's now included within safeguarding training specifically to make people aware of this wider issue for organisations. Locally in Cumbria, as an aside, we have recently had a successful prosecution, which I think I referred to in our quality committee recently. A custodial sentence was handed down by the judge relating to a Cumbrian resident who had experienced modern slavery. So it's clearly not something that happens in just big cities. This is something that's very relevant to Cumbria. And I'll take any questions.
Okay, thanks, Molly. Any questions or comments? Colin?
Thanks for this report, Molly. You and I sit on the refugees subcommittee. Folks may not be very aware of this subcommittee, but there is the Afghan resettlement and there are the Syrian resettlements, and Cumbria provides its share. The reason I bring it up in this context is at most recent meeting, we talked about Hong Kong residents coming to the United Kingdom, and we talked also about Ukrainians. And I'm just making people aware that there is going to have to be care, John, in this arena, because we think about slavery in a particular way, but this also talks about human trafficking. This often we think of evil people looking evil. No, people look like people. And we just have to be sure that as the country welcomes the Ukrainians, and it's already welcoming people from Hong Kong, John, that we play our part in networks so that people we want to bring here to help don't end up getting caught up in things that we wouldn't want them to be caught up with. And whether Molly wants to say something about the fact that these things just don't happen because nasty people meet in rooms and do nasty stuff. Sometimes these things happen because we don't organise ourselves correctly. Thank you, Molly.
Okay, yeah, thanks, Colin. I think that is a very sound linkage. Without one, I know that you will be tight for time in this meeting, but we have established, as Colin said, that health subgroup for all matters relating to health for the well-being of refugees, and people have all sorts of ideas about what modern slavery actually looks like, and in reality it is serious organised crime that goes all through organisations, and certainly having worked in a big city and come close up to many cases, it's, you know, you really have to keep your pencil sharpened, and that's why we're giving this assurance to the governing body today that we have our mind's eye on this.
Okay, thank you. Nikki?
Yes, thanks, Chair. I just wanted to commend Molly and her team, because she's done a lot of work in implementing some training across all areas in the system to support this this statement, and I just think we should acknowledge that that's much more improved than it has been previously.
Thank you. Thanks, Nikki. Thanks, Molly. Just, is there any other questions before? Just one question from me, Molly. Just as regards, when we talked about supply chains, which is one of your key points in your report, what things do we actively do to try and check that out? What yeah. Just can you try and articulate to us all what happens?
Yeah, absolutely. So imagine that we are there's a situation arisen where we are going to procure a new service or renew a service. In that procurement process, we ask for a plethora of information, and within that document suite, if you like, there are particular checks done. So if you're going to be a company director, there are a set of standards which must be met, and they are closely looked at. And if people have not met those procurements, just in the way that Charles would through a lens of finance, there are equally components that we would filter somebody out. Also, alongside this is the safer recruitment policies that are in place, which we're all aware of, and our ensuring that we have complied with DBS enhanced checks, etc., depending upon what that service is. You know, right to work is significant because it's not exclusively involving people who are not British in background, but there are many case studies of where people are noted to be more vulnerable and they're brought into the country. So what Colin was referring to there is we have an established resettlement programme aligned to our Syrian refugees and our Afghanistan refugees, Ukrainian refugees. That's kind of just being developed now, and there's been some real pushback about those challenges. And in reality, when this goes wrong, what happens is you get a lot of people magnetising towards a situation, and I experienced this firsthand at Grenfell, and that coined the phrase tragedy tourists. And it's at just that point where community members may present as being bona fide acting in goodwill and wanting to set up, for example, talking therapies, but they haven't undergone the appropriate checks which this Act requires us to. And therefore, they're the ones that will magnetise towards those, and we have to filter them out, and we have to adhere to what the framework laid down is.
Okay, Molly, thank you. Mandy.
Yeah, thanks, Molly. Just while you're talking, I'm also thinking about, I'm assuming the local authority have the same obligation to have the same kind of policy as we do in the CCG, because obviously social care, it's very important for them as well, isn't it, to make sure that this isn't happening under their watch. But I suppose I was specifically thinking about other examples where it may be more difficult to get the assurance. So things like some of the private providers that currently provide services, we know, within Cumbria for children in the looked after system. Do we get the assurance from them that, again, that the same thing isn't happening?
So all organisations have to publish their statements. So if you're going to buy a beautiful handbag from Gucci, Mandy, they have to too. So it goes right through the supply chains, because the cases that have come forward just cover every element of our society, all elements. It's not just the car wash companies that jump to mind. You know, other cleaning companies, because it's serious organised crime. One case I was involved in very quickly was a myriad. So people will come into the country with an aim for employment in good faith. Passports have been taken off them, high level of control. They are totally reliant upon to their slave master for food, for transport, communication, welfare and employment. And when they find themselves here, they are not actually occupied in the remit that they thought they were going to be. So this is how somebody might come in and they're being forced into, it could be sex workers, that's one of them. And then when they're past the sell-by date in their slave master's world, they then will become drug mules. The whole thing is connected to organised crime, which is hideous. You know, I could say I unfortunately have had a number of these cases when I was in London, and you just, you know, you wouldn't believe it. So you might think you've got a cleaner and somebody else, you know, is controlling that person's entire world.
Okay, thanks, Molly. Okay, Mandy, we okay to move on? We're to the next. Okay, just thank you, Molly. One of the things we asked to do was to ratify, not approve, ratify. So I'm not going to go for a secondary proposal. Are we all okay in terms of all our governing body members just to ratify that? There's no dissent from that. Okay, right. Thank. You've got full ratification, Molly. Thanks for the work you do, and we really appreciate it. Thanks for attending today.
Thank you. Bye.
Bye bye. Okay. We had an item 9, but you'll notice that that's been deferred to part 2 due to it containing some commercial in confidence material, and that will become evident when we go on to the part 2. So I was going. I take, is Christine here yet? Don't worry if she's not. I can't quite see her. No. Okay. Well, can we do yourself then, please, Nikki? Item 11, the quality report.
Yeah, certainly can.
Thank you.
So members will have seen this report, which is actually not only the RAG table that we would normally show you, but also the full narrative that supports that on this occasion. So it's some 60 pages long, so I'm just going to highlight the main areas of concern and good practice, and go through what's in the highlight report. So basically what we've tried to do with this report is to start and have a look back over the year. But as it was written in February, obviously we can't give you a complete year-end view. So for this reason, as well as this report, we want to bring back to Outcomes and Quality Committee and Governing Body in May a further slide deck presentation, which is much more of a look back over the year and identifying our priority areas going forward. So that's sort of more work to come. But in terms of the main themes that we've highlighted in the cover sheet for this quality report, obviously the main area in red has been for some time is the progress with our constitutional targets, which is challenged in all areas, and that's mainly due to the continued pressures from COVID. So I think really just to say, in many ways, looking back over this second year, for us it's felt worse than the first year in many ways. Even though we've had fewer hospital attendances with COVID, our services, as has been mentioned, is trying to manage business as usual. We have had an acknowledged pent-up demand and subsequent higher acuity of patients. And whilst this is happening, we're also experiencing huge workforce reductions caused by further waves of the virus, particularly with Omicron, which is still sweeping through our workforce and our community. So it's been a very challenging year, as everyone knows. So in respect of our A&E performance, I think particularly the 12-hour waits has been high on our priority to try and receive some assurance from the Trust around the sort of patient safety aspects of this issue. Obviously, we're trying to look with them at why we're having the 12-hour waits, and lots of work has been acknowledged around the medically optimised numbers and the issues that go along with that. But from our point of view, from a quality perspective, we're looking to try and have some assurance around if somebody is requiring admission, they are transferred to a bed, not left on a trolley, that they have their observations, they have their sort of food and hydration needs met, and their treatment started. So that's been a big priority of work for us, and we are getting assurance on that aspect of it. As you'll see from the report, the referral to treatment performance continues to be challenged as well, and they were wanting to have a pre-COVID level from the 62-day waiters, but that's unlikely to be achieved. I think that's not been met. However, the progress has been made with 104-day elective waits, which, following some really good focus work at the Trust, has reduced down to, I think, around about 59 by the end of this month. I think other areas to highlight for governing body are, and it's been alluded to a little bit in terms of Molly's item, that we have had an increase in safeguarding referrals. You'll see in the report that this includes the safeguarding adult reviews and the domestic homicide reviews. We have 23 open safeguarding reviews, which is really unusual to have that high number. And it is indicative really of the likely harms that the hidden harms that we suspect happened during the COVID period. Just to let governing body members know that we are expecting the second version of the Ockenden report to be published on the 30th of March, and this will continue to give us some more opportunity to review with the Trust our safety and quality of our maternity services. So far, we've received good assurances from the Trust with regard to Ockenden action plans, and their compliance against targets has been good and been well received nationally. But we do await the further actions from part 2 of the publication. So we will be doing more work with the Trust on that assurance. I think we wanted to highlight some achievements for you. So obviously, needless to say, the success of our vaccine rollout this year has been worthy of note. I think we're at sort of over 90% generally in our local population, which has really been an excellent achievement. It has had associated pressures, obviously, within primary care due to us focusing on that, but nonetheless, it's worthy of note. Other achievements are in relation to the continuing healthcare team. They have managed their priority of backlog work from their reviews, and they've also done that at the same time as supporting the wider system with complex cases, the sort of fragile domiciliary care and the delayed discharges. So they've worked tremendously hard to achieve that work. Likewise, in respect of the leader review project, where there's been a new national policy and an extension to include people with autism. That's been implemented, and we continue to work really well and collaboratively with our local Confirm and Challenge group. So they work to quality assure our reviews and to ensure that the action from learning is disseminated across the system, and it's done in a really user-focused way. So that's been really a good piece of work. I think overall we are seeing indications that outbreaks and inpatient infections are starting to stabilise in the local area, but obviously with the ongoing impact of the high hospital attendances and the work around recovery, I'd say, and the whole staffing pressures that we're having, we still have concerns. So I think coupled with the numbers of medically optimised patients and the fragility of the care packages that we have, I think we've got some priority areas to focus on in terms of our recovery for the coming year. I think lastly, I just wanted to say, needless to say really, but just it is worthy of note just how hard the clinical staff and the CCG staff have worked to try and keep quality and safety as a priority focus, despite the many challenges that have gone on this year. It is front and centre, something that they're all trying to work to carry on and have as a high focus. And I wanted to particularly thank Carol and Denise for their support in refining our approach to reporting and assuring quality. They've worked really hard with us this year too. So this report was considered in detail at the Outcomes and Quality meeting on the 2nd of March, and so it's been scrutinised well, but obviously there'll be some questions you want to pick up. I just wasn't sure whether Carol as chair wanted to add any further comments to the things that I've picked out.
Thanks, Nikki. Thank you. Carol.
Yeah, thanks, Nikki. That was a very good, comprehensive summary. You know, we are experiencing a lot of real pressures in the system, but what I am impressed with as chair of the Quality and Outcomes Committee is those real glimmers of achievement that have been happening across our health system during this really difficult time. And I know that Nikki has mentioned some. There are a couple of others. Particularly the work that's been done under the enhanced healthcare in care homes approach, the health call system, and also the new quality and safety dashboard. I mean, that's taken a lot of work, and I know that the health call system's being piloted at the moment in 6 care homes, but given the fragility of the care home sector, I think these two innovations that we are leading together with our social care colleagues are really worth mentioning, Nikki. And I think the other work which I would also mention is the end of life strategy development as well. So just to point you in the direction of that section on the report too. And then finally, I think the even though we have the long waiting lists, it's been really assuring to know that the Waiting Well work that I think Mandy is involved in is is also progressing now. So just wanted to mention those extra areas to give a bit of a balance between the huge work pressures, but also the positive work and the type of work that's actually improving people's health and well-being in Cumbria. So thanks, Nikki.
Thanks, Carol. Mandy.
Thanks, John. Yeah, so just a reflection as well. I mean, it sounds like a lot of serious case reviews, doesn't it, when you put them all together? It's certainly a much larger number than previously as a safeguarding team that we've had to deal with. But it's starting to feel, I mean, obviously I can't tell you the detail of this at the moment because it is not a review that's being published as yet. We're still in the working out process. But the author of one of the adult reports was particularly interested to hear about integrated care communities in North Cumbria, and is actually considering including that in the recommendations to the Safeguarding Board. So I think it's worth kind of noting that the work that we've done on ICCs in North Cumbria, I think going forward we'll be able to build on that as being a really meaningful footprint for some of the recommendations going forward and some of the learning from safeguarding reviews. So I thought it was worth a mention. Obviously, at some point we will get the published report on that, but yeah, it was a very interesting learning event to go through.
Thanks, Mandy. Are there any other questions or comments from anybody that people want to raise? Colin?
This is more for information than for anything to be done, but in the freedom to speak up part, there doesn't seem to be an indication if the freedom to speak up guardian is having anybody using. Am I reading it wrong? At the moment we're doing the training, we're doing all of the right things, and that's great, but it just doesn't seem to be any indication if it's working. So I'm not saying it's not working, by the way. I'm just saying the report doesn't outline that. So it's not a complaint. It's just we need some evidence that whatever we're setting up is doing what we hoped it would do. Thanks.
Okay, Denise, do you want to add something to that? Sorry, Denise. Sorry, you're gonna have to.
Sorry, John.
There you go. That's okay.
I think I think the system is working. The information is getting out there. There's an awful lot of work going on, and about to be going into team meetings to do the training there, which is again raising awareness. But for clarity, there has been no cases brought forward within the CCG. Within the wider system, there are lots of cases under the freedom to speak up being brought forward. And that was up to date as about 2 weeks ago when we last met, Louise. And we meet about every 4 weeks, and that was up to that point.
Because that's your role as a sort of lay member lead, Denise, for freedom to speak up. Yeah. Okay. Thank you. Okay. Anything else that they wanted to touch on in terms of quality? And I think you can only echo that real challenges, which we've spoken about on a number of occasions, sadly. So we're asked to note that report, which we will do. And I think it kind of leads on to, I'm just checking, I don't think we've had Christine turn up. So I'll just move on to the performance report, which is linked again in terms of.
Sorry, John, I am here.
Sorry, Christine. So sorry, I do apologise. All right, if you're here, then Christine, we won't keep you back. Actually,
John.
So, go on.
Sorry, John. It's Charles. I just wonder, given it follows on, it might just be worth doing the performance report.
Yeah. Okay. All right. No,
that's
fair.
Okay.
Fair enough, Charles. Yeah. Yes. And you had a long stint at this yesterday, doing performance and finance reports at left, right, and centre. So yeah, go on, Charles. We'll go on to.
So I'm not going to say a huge amount because just because of the time in this report, actually the way we get things, a lot of it relates actually back to December, and I think at the last meeting we predicted when we got the figures for sort of December, January, they would be worse than we'd seen before, and that prediction was correct. I think what we have to remember is during that time we had the new outbreaks of COVID that had a double whammy. More people were being ill, but also massive increases in the number of people who were having to self-isolate, which was causing problems in the hospital for staff, problems for patients making appointments, problems with people being ill, problems in primary care right across the system. So we saw that, and Nikki's articulated a lot of the issues. And it wasn't just in the acute sector, those absences also presented in, for example, mental health. So we saw a deterioration in some of the progress that had been made by CNTW. As has been said, the position at the moment is not great. We are starting to see the trust achieve some of the things that they've predicted in terms of managing long waiters and bringing the numbers down. And I think probably they have performed better than some of us might have predicted. They have been doing these marathon weeks and the like. And what we said at the Finance Performance Committee yesterday is probably we bring these reports along, and we get a snapshot at a point in time, and we highlight some of the things that have been done to address those things, and perhaps we need to step back and just look over a bit of a longer period what's happened and understand some of the trends. So we're going to do that for next time's report. So I'm not going to say a bit more on this, but just a cup to end on a positive, albeit it's only 2 days, but 2 days over the last 2 weeks, Northwest Ambulance Service have met every national standards on the ambulance performance framework, which certainly compared to the rest of the Northwest is an absolutely brilliant performance. So I think it's important to put some highlights in. And again, yesterday, despite the numbers being very pressed at both hospitals, the average turnaround time was less than 30 minutes. So again, there are some green shoots there. There are a huge amount of challenges, but hidden within that, there are 1 or 2 green shoots of recovery. But as I say, what we said yesterday is perhaps try and have a step back and look at some of the longer term things and try and look at perhaps some of these initiatives. Have they had the impact that we expected them to have? And we can start to play that in as we look at next year's plans, and that should hopefully give us some confidence or make us ask some more questions, a bit like John and Peter were saying about the delayed discharges or the medically optimised patients, about what things might work. And actually, if we've done things but there's no evidence that they've had any impact, then we might want to think again. And that's also applied to, for example, some of the work that we've undertaken with the third sector to try and support people, but to live more safely at home and be discharged from hospital. Some things have worked well, some things haven't. So we're using our best endeavours to carry on the things that are working well, but not so much the things that haven't. So just really wanted to say that, but I thought it was timely to share that information given the big overlap with the report that Nikki's just presented.
Yeah, thanks for that, Charles. Appreciate it. Any comments or questions on performance? Okay, well, we're asked to note it again, which we will do, and we'll now go back to item 10, which is yourself, Christine, just to do us a brief overview on the Equality, Diversity and Inclusion report for 2021-22.
Thank you. Just to say that there was no public need to produce a report last year. The public sector equality duty was suspended during COVID, but that's now changed, and they're expecting all organisations to publish a report by the end of this month. Just a brief thing on the population. The North Cumbria population is just over 328,000. It continues to grow at the older end of the scale and reduce at the younger end. For instance, the over 65s is 24.5% compared to an England average of 18.5%. And the younger age group is below the national average as well. Our BAME rates are increasing slowly, but still a lot lower than the national average. I used the sort of village of 1,000 people because I actually thought I found it when I was looking for something else and thought it was gave quite a good comparison of the state of North Cumbria. If you look at the long-term conditions, that the 320 in the 1,000 equates to 105,000 people within North Cumbria having 1 to 3 long-term conditions. So that just gives you a scale of the problem. And I would imagine that the fuel poverty figures are likely to increase dramatically with the rise in electricity and gas prices that we've got coming up. The majority of the report is focused on what we've done over the last year to address the inequalities in the COVID vaccine, because obviously that's been a big tag, a lot of work, certainly for the primary care team and others. We've had a small group of multi-agencies looking at the data and identifying where the gaps are, and there's some really good work has gone on to address where those gaps are to address the inequalities. There are examples in the report looking at the sort of vaccine bus that went around to various places, the Appleby Horse Fair, Carlisle College. There was lots of initiatives with the Cumbrian Farmers Network, working with the Gypsy and Roman traveller community, where there was a trusted person identified by the County Council who produced a lot of good work with the Gypsy travellers. Patients with learning disabilities, there were special clinics put on for those, where in places that they knew. An interesting one I thought was the homeless patients one in Workington, where they went into a hostel to vaccinate the homeless who were being housed there temporarily, and actually found someone with a broken leg who managed to get treatment that day for it, and somebody else with untreated ulcers that also got treated on the same day. Also, there's been lots of information available on the website in alternative languages and formats, including short videos, one in British Sign Language. And I think it goes to show that the work was achieved what it set out to achieve, because if you look across all the cohorts, North Cumbria was always in the top 3 across the North East and North Cumbria for the percentages of people who'd been vaccinated. The trust reports are both now on the website for this year, for the EDS reports, the Equality Delivery System reports. And there's links in there there's links in this report to those. When I actually wrote this report, NCIC hadn't published this year's report, but they have now. And so what they've been looking at this year is different to what it actually says in the report, and I can change that before we publish it if that's okay. And it says that they've aligned their equality, diversity and inclusion action plan to their people strategy, and their goals are looking at developing a suite of zero tolerance initiatives, developing a range of targeted initiatives that celebrate the diverse workforce, growing the current range of support mechanisms to represent and influence areas of diversity, reviewing the current EDI training offers, and maintaining statutory and regulatory EDI organisational compliance. And if, because we have to publish this report, I will change the bit on NCIC in this report before we publish it, so it's more up to date. I've been involved actively in a North Cumbria ICP EDI lead, apologies for all the initials, and that's made up of representatives from the CCG, NCIC, CNTW, the County Council, the Police and the Fire Service. A lot of discussion there is around workforce and staff networks. All of those organisations have staff networks for, say, BAME staff, disabled staff, LGBT staff. We don't have those, obviously, networks of the CCG because our workforce is so small, but the workforce was, the information about the networks was provided to staff to enable them to join them if they wanted to. And they are looking at how they might bring those networks together going forward, and starting off with a joint event later in the year. And I'm assuming that going forward, the CCG's equality responsibility will be covered by the ICB. And maybe that's something that we need to ensure that takes place. The rest of the report is the kind of standard thing that's in everyone about the accessible information standard, workforce equality standards, and the legislation. So I'm hoping this will be my last report of the CCG. But as I say this quite often, and I've never managed to get rid of it yet, I'm keeping my fingers crossed.
Okay, thanks, Christine. Colin?
So thank you very much for all the work you do in this, Christine. And I want to express my hope that you don't stop doing this, because what on earth are we going to do if you're not doing it? But however, Peter's given a wry smile there. I hope that doesn't mean he's going to delegate it to me. However, I want to commend your use of the idea of 1,000 village as a notional way of people getting their head around what can seem to be a bewildering snowstorm of data. And if I just may, John, in the little infographic provided, this shows how insidious some of these inequalities can be, because we often understand postcode inequalities that you might call or think of those as sink areas, or areas that seem to get stuck in a very particular way of society not working as well as we would hope. But if you look in the infographic, you'll see that in a village of 1,000, 143 people live on their own. And people may have remembered me speaking about how corrosive loneliness is associated with very poor outcomes. And eye-watering, 1 in 7 children in low-income families. My goodness, what are we storing up there? Don't get Mandy going. We're storing up a lot, basically. And then just as my third, of the 72 people per 1,000 who have 4 long-term conditions they consume, that is their condition, not they as people, but their condition. And the way it happens, 21% of all our secondary care resource. You may say, well, of course, that's why we have secondary care. But what, of course, our wish would be in primary preventative terms is to best stabilise these folks so they didn't have to make so many journeys to secondary care. So I do think that infographic and that sort of insight into the insidious nature of inequality it is very helpful. So thank you very much, Christine, and long may you be reporting. Thank you.
Thanks, Colin. Denise, then Charles.
Yeah, I also love that infographic. I think it really brings out exactly where we are. I've seen it used before in other areas, and it's really good. I just want to say thank you to Christine for pulling out the COVID work. I think it's a really good summary of the innovative practice that got us to where we were with our very high rates of uptake. And I think we need to take the learning and reflection for our wider health inequalities work, because we're doing it within that work. There's so much that happened then that can inform us as we go forward to trying to tackle some of these inequalities. You know, let's really go to where the people are. Let's go and meet them on their terms. That's what we need to be doing, and that's what we did there. Thank you.
Thanks, Denise. Charles, and then Mandy.
Thanks, John. I don't want us to go down a rabbit hole, because I'm sure lots of us find that village of 1,000 people really fascinating. But there is one thing in there that I was very, very surprised about, and I wonder why that this might be one of the issues when we look at how resources are allocated at a national level to North Cumbria, is that in that village of 1,000 people, actually the median wage for working men is £1,000 higher than the national average. That, to be frank, given what the majority of jobs there perhaps are in, we don't have a load of hedge funds and merchant banks, as far as I was aware, based in North Cumbria. I was quite gobsmacked to see that. But I think it's the way, as Colin has described, the issue always with Cumbria in terms of getting resources is we have extremes, but they're sort of covered up by the average, and it's just a flag. It's always worth going past the figures, because they don't always agree with what's going on, and it might be because those figures are high, but we have a lot fewer people working. I don't know, and I don't want to debate that now, but it's just saying some of those things are actually quite counterintuitive from what we'd expect.
Okay, thanks, Charles. Mandy.
Yeah, I totally agree with what everybody said, but I suppose just building on from what Charles has said, as we all agreed, the infographic is fantastic, isn't it? But it would be good to have a comparison. And I just wondered, Christine, whether you knew if other areas across North Cumbria have got a similar infographic that we could compare to, because you're absolutely right. I know Peter's talked about this before, about the fact that working age adults, we do seem to have an issue with in Cumbria, but to be able to have that information, we need to be able to have that comparison to be able to make that point clear.
Thanks, Mandy.
Sorry, I was just going to reply to Mandy. There might well be, because the information came from NEXT, so I would imagine they could be doing it for other CCGs as well. And just for that national average of the wage thing, it might be interesting to look at the ones that they are available at an ICC PCN level, and it might be that a certain area has influences that wage more than others. Because I know, let's face it, Sellafield all are on a lot of quite high wages these days, so that might be the one that makes it look abnormal.
Yeah, thanks for that, Christine. Mark.
Other CCGs do use them, and as Christine says, NEXT colleagues have helped us do that in other CCGs. I think it would be worth us going back to NEXT and just finding out what other CCGs use them on a regular basis. But they've also come back to the fore relatively recently with the focus on inequalities generally. So I think more people are turning back to them that might have used them before. So I definitely think it's worth having a discussion with NEXT.
Okay, thank you, Mark. Any more comments, questions? I was just going to ask you, you might not know the answer to this, Christine, but I'll start with you. If we are changing our commission services quite significantly, is there automatically an equality impact assessment done alongside that change, just to check out whether or not there are going to be, or is going to be, a portion of the population disproportionately affected by it? Is it a routine piece of work?
It should be.
Okay, so I can see why, I can see very clearly how we've done it with COVID. I'm just wondering in terms of some of the other significant things in terms of commission. I suppose I'll maybe ask yourself, Peter, if that's routinely, or Charles, just.
Yeah. So, John, the answer is yes.
Okay, right.
It being a legal duty, and we would be open to
all
kinds of legal challenges if we pursued a a planned service change without having proper attention to our equality duties. The impact assessment is kind of 2 stages though. So the first, Christine will be able to answer this more fully, but the first stage is effectively kind of a screening stage. Then the second stage is more in depth. If there are any issues identified for any communities that share protected characteristics. So yes, this is something that we would be expected to do.
Yeah.
And picking up a little bit on the way Molly described the modern day slavery assurance work, it's also something that in our commissioning role, we should routinely be requiring from service providers when they consider such issues as well. Okay. So, for example, in the recent plans that have been discussed elsewhere about the community diagnostic hub, one of our questions to NTIC was if they could demonstrate they'd undertaken appropriate quality impact assessment. So the answer should always be yes, where applicable. I think there might be a further challenge for us, Christine, and is just making sure we've kind of got this as robustly throughout the whole organisation as we would need to. But the answer really should be yes.
Okay, thanks, Peter. Charles, and then Mandy.
So, not trying to at all contradict what Peter's just said about the process. It's more a practical point. Is the main reason we should be talking about COVID is because under the way the NHS has been operating over the last 2 years, we haven't really commissioned anything other than services specifically to deal with COVID. But what Peter says is a very timely reminder that as we move forward, and hopefully we are going to start doing that again, then it's really important that we do undertake that work. But probably, to be fair, there's not a huge amount of new things that have not been relating to. I've just seen someone's put in the chat about waiting well, either the direct impact of COVID, so the vaccination, as Christine referred to, and picking particularly vulnerable groups, or the indirect impact, which is issues like waiting well, where people are waiting a lot longer than they previously did for operations. But the bit, again, a bit like some of the performance issues, taking these things into account and making sure we don't forget about them going forward is really, really important.
Okay, thanks, Charles. Mandy.
Yeah, it was me that was about the Waiting Well project. I mean, we did have a demonstration as part of that regional project on the dashboard that NECs have been producing, and it's a really, really useful tool, I think, going forward that will really help that we can build on for the health and equalities work across the region. I'm not sure whether Mark's seen it at all, but certainly we were all very impressed clinically when we saw that dashboard being presented. I think there are still some issues about its development, but I think most of those are being worked through now, Mark, as far as I'm aware.
Yeah, okay, thank you for that. Thanks, Mandy. Julie.
Oh, sorry, I thought to turn my hand down. Peter answered it very eloquently. I was just going to explain the process. It should be in there though, definitely. Thanks. Okay,
thank you. No, got that. Are we all okay with that? Yeah, I think what we asked to do is approve the publication subject to the alteration that you were going to do, Christine, for NCIC. So approve that for publication on our website. Again, it's not a sort of a bigger decision for us. I'm just asking, is there anybody who disagrees with any of that? No. So from the board's perspective, please put that on the website, Christine. Thank you again for all the work you do. It's a very useful, timely reminder for us in terms of the diversity and the equality and all the inclusion issues that we need to consider as organisations, particularly as we will get bigger as an organisation, and that will change that dramatically in terms of the size of the ICB compared to us currently as a CCG, the size of us. Okay, right. Thank you very much for that. Thank you. We're going to go on to finance report now. Charles.
Thanks, John. Hopefully, I'll be relatively brief on this, because I know a large proportion of the governing body listened to me talking about this for a long time yesterday. So the report you see is the January report. Since the papers went out, we've completed the February report, and we're still on target to manage our agreed deficit. We've seen the odds ups and downs on a number of budget lines, but overall we continue to go. Just to flag a few things of interest, the hospital discharge programme comes to an end on the 31st of March, but I think it's important to say, in terms of some of the previous conversations, we've used, I wasn't going to use the phrase every trick in the book, but we have taken every opportunity to work as constructively as possible with our partners to use that process to its best effect. So in terms of trying to do things, we've certainly done that. Secondly, just again a bit of an observation linked to the last item, is that it's interesting because where money has come out specifically for issues of for example, health inequality, there was some money came out for general practices, and we didn't get any of that, because when it was allocated, there were places in other areas that were deemed to be on, if you like, the list of prioritisation higher than ours. So that's always something, as we move into a new organisation and we start looking at health inequalities, they're going to be looked at across a much bigger footprint than just North Cumbria, which goes back to the point about making those things key. I think the other thing is just to say, in terms of elective activity, we continue to see a lot of patients going over to Teesside, actually, particularly for cataract procedures, which does show that the difference between patients being willing to travel probably for relatively short-term interventions where they're only away for a day or so, as opposed to the need to ensure that we have locally provided services for again the patients that Colin was saying about, those, I can't remember, 72 people in every 1,000 with 4 or more long-term conditions, who, if there weren't those processes, those services that could access locally, no doubt that would make their very difficult lives even more difficult. So just quite interesting to look at those things. But in terms of the finances themselves, they continue to be as expected. It's sort of a bit weird because we've done the finances in 2 halves. So normally at this time of year, we're looking at a full year's financial performance, whereas in effect we're only looking at 4 months, because we had the first 6 months of the year with the money that was all closed down, and then we started again. So nothing in particular to note, but thought it was helpful to bring up those perhaps wider points to give a bit of contextualisation.
Okay, thank you very much, Charles. Anything question-wise or comment-wise on the finance report before we move on? Okay, no, thank you. So we're going on to the minutes of the relevant meetings now, just for acceptance and noting. So I will give opportunities for each of the chairs to see if there's anything they wanted to add from those. So I'm just going to go on to Exec Committee for the 23rd December and 27th of January. Anything from that, Mark, that you wanted to pull out? No? Okay. Finance Performance, which is myself, there's nothing that I want to pull out from that, but is everyone okay? Yeah. Outcomes and Quality Assurance Committee, anything from yourself, Carol, you want to specifically pull out? No. There's 2 primary care commissioning committees, October and December. There's nothing from me on those that needs drawing out. So happy to accept all those before I move on to the, yeah. So item 15 minutes of the wider system, just the Cumbria Health and Wellbeing Board on the 3rd of December. Just wanted to note a couple of things really. One is still the increased, should we say, concentration on special education needs and disabilities for people, and there's still a lot of work going on that, which I know a lot of colleagues around this screen will be aware of. And the fact there's still work to do. They're hoping to have an inspection soon, and we'll be able to get a better position as to where we are organisationally in terms of SEND. And then the other two things there, just the process that was being undertaken for both the joint strategic needs assessment and the pharmacy assessment that we have to do as a health and wellbeing board. So the process is outlined there, and work underway on doing that. There's no meeting minutes from the ICP leaderboard, and there's nothing that I really wanted to pull out in terms of the Northern Joint CCG committee. Those committees at the moment probably doing more of a development role and a link between CCG's chairs and the council officers, and with now Sam as the new chief executive, and who's embraced that group, I have to say, and comes and gives regular updates as to where we are to make sure that there's that connectivity, and it's not just done through AOs like Mark, it's done through the chairs and the AOs. So everybody okay with that? Yeah. I haven't got any questions from members of the public at all. Just double checking on that point. Brenda, anything that you've received whilst we've been on air, as it were? No. Is there anything from any of our colleagues actually who probably don't join the meeting as, say, full members? Anything from anybody that wants to mention? David, anything you wanted to pick up question wise that you've not had a chance to pick up today?
No, there isn't. There's a couple of, I've got a couple of performance and quality type things, but I'll send those in if that's okay, just because I missed that part of the meeting. So
okay,
sincere apologies about that, but
right.
I'll send them in. And,
okay, thanks, David.
That might be easier.
Yeah, appreciate that, mate. Tony, anything from yourself?
No, thanks.
Okay, no, thank you for that.
Thank you.
I haven't got any other urgent items of business, item 17, but one thing I just wanted to check is, you'll probably know this better than anybody, Suzanne, the staff survey, when does that get released publicly?
It's the 30th of March.
Okay, so we'll probably have it on the next meeting then.
Yep.
Okay, well, thanks for that. So, date and time of next meeting, Thursday, the 19th of June. Obviously, we'll have a development session in between. So I wanted to close the meeting. Thank everybody for their attendance. We will have the part 2 soon, shall we say. I'm just looking at the time now. I just make it about 33 minutes past 2. Should we convene again at 2:45? Give a chance to get a break and a drink, and then we'll crack on with part 2. So, Charles, before you go on. Charles?
Yeah, can I just remind you, there's a separate link for the part 2 meeting.
Yes, thanks very much for that. That's a good reminder, that, Brenda. Thank you. Charles?
So just to check, because we approved that the delegation of the budget setting to finance and performance, and it would be ratified at the May meeting. So clearly we can't do that if the next meeting's not till June. So we're not having a meeting for 3 months. Is that?
Yeah, just I'm looking at that.
Is that correct?
Technically should be in May, shouldn't it, Brenda?
I think it should be. That's my typo on my part. So with me, it will be the 19th of May, Thursday, the 19th of May.
Yeah. It just shows you I just read what's in front of me and I don't think about anything.
And I'm so pedantic as well.
No, you're right, Charles, and that's what happens. That's very good. No, I appreciate that.
Great teamwork with different skills.
Thanks very much. Okay, so we'll meet back on a new link for those that go in the part 2 at 2:45, and thank very much for those that are leaving us, and thanks for attending the meeting and contributing. Appreciate it. Okay, thank you.
Thank you. Goodbye.